Dr. Shanti is another metabolic geneticist, but she's at the Children's Hospital here in Sydney, the one at Westmead. She's contributed to Mito Foundation in many different ways, including being a member of our scientific and medical advisory panel, but continues to always answer so positively when we ask her for help. She was one of the co-authors on the patient care standards for primary mitochondrial disease in Australia. And these standards, and we have sort of created a companion resource, which is just up there. You can see the white booklet with the black and green bars on it, monitoring Mito, and we've also adapted that into a GP training module. We hope are a way to create some pathways into understanding what is the care that's required, particularly tests and checkups that might be right for you, and that can support conversations with your whole healthcare team, but particularly your GP. And as we all know, GPs are always on a learning curve with Mito. So today, Shanti's going to explain how these tools are already being used to improve care and how you might be able to use them to feel more informed and confident into managing your health. Thank you, Shanti.
Good afternoon, everyone. I'm Shanti, as Claire's explained. I'm a metabolic geneticist and a biochemical genetics pathologist, and I'm based at the Children's Hospital at Westmead. Sorry. Okay. Right. We are part of the Sydney Children's Hospital Network, which is the largest pediatric healthcare service in Australia. So my unique role as a clinician and as a pathologist is actually really beneficial because it has helped bridge the gap, hopefully, between laboratory medicine and clinical care in the archetypal bench to bedside model. I will have to apologize beforehand if I seem a bit distracted because I am on call and I have a patient that is about to be admitted for an important procedure. Right. That's me. Yeah. So many of you in the audience today would have heard over the last 2 days and from previous Mito Foundation symposiums or community events, and are perhaps fairly familiar with mitochondrial disease. Hence, some of the content of my presentation may appear to overlap previous presentations or repetitive. However, it is hopefully will facilitate a better understanding of the rationale behind the recommendations for surveillance or monitoring of patients with Mito. So the mitochondria, sorry, I don't know if this has a point.
It does. Sorry. We've gone so quickly, that one's amazing.
All right, thanks. So the mitochondria are specialized structures or subunits within the cell that carry out crucial function, the most important of which is energy production that is performed within the mitochondrial respiratory chain. Anyway, I'll forget how to use it, which is a 5-enzyme complex that is embedded within the inner mitochondrial membrane. And the mitochondrion, which is singular for mitochondria, is a highly efficient energy generating machinery, which produces about 90% of the body's energy requirement to sustain life and support growth. So this process of burning food in the presence of oxygen produces the chemical form of energy, which is adenosine triphosphate or ATP, in a process called oxidative phosphorylation, which is also termed as aerobic metabolism. In addition to energy production, a whole host of other vital processes occur within the mitochondrion, including the breakdown of fatty acids, proteins, and programmed cell deaths, as well as the production of reactive oxygen species. So what are reactive oxygen species and what is oxidative stress? So ROS, in short for reactive oxygen species, is also known as free radicals, and these are toxic byproducts of aerobic metabolism produced within the mitochondria. They are involved in reactions called oxidation, which is necessary for the bodily function. Oxidative stress, however, occurs when there's an imbalance between free radical formation and the antioxidant activity, which can damage fatty tissue, DNA, and proteins in our bodies. Oxidative stress is also responsible for the natural process of aging that occurs in all of us. So primary mitochondrial diseases are genetic disorders that directly impair mitochondrial structure and function, and it's caused by mutations that are inherited either maternally from mitochondrial DNA or nuclear genes. The worldwide statistics have varied considerably over time, but conservatively, from Australian studies, it approximately affects 1 in 200 individuals. Sorry, 1 in 200 individuals carry a mitochondrial genetic defect, which equates to nearly 120,000 Australians who may carry genetic mutations that put them at risk of developing mitochondrial disease. However, not all individuals carrying a genetic mutation in mitochondrial genes will develop the disease, and many may manifest subtle signs and symptoms or may never present during their lifespan or lifetime. So the risk of developing serious illness in the general population is approximately 1 in 4,300 live births. So that is not infrequent. All right, so mitochondrial disorders represent a clinically diverse group of conditions that can affect any organ system at any age. And children within the same family may have differing clinical symptoms if they have a mitochondrial DNA variant. There is, however, a predilection of organs with high energy requirements that use a lot of oxygen. For example, the brain, muscle, liver, heart, retina, the hearing apparatus known as the cochlea, and kidneys being particularly vulnerable. And this predisposition can be attributed to its critical function in cellular energy production. So why is it then so important that we emphasize on monitoring or surveillance for mitochondrial disease? Because it's important to note that these disorders affect the body's ability to produce energy, and their effects can be progressive, multisystemic, and potentially life-threatening if not managed appropriately. These features may worsen or deteriorate or decline over time as energy production continues to decline. Hence, regular monitoring is essential to help detect early symptoms, signs and symptoms, or progression of disease or new organ involvement, and it'll help facilitate interventions that can be started promptly. So we are fairly familiar that there have been no curative therapies for mitochondrial disorders, though it's promising that lots of clinical trials are being engaged in the adult population. However, at this stage, the current approach is a multidisciplinary, holistic approach that not only targets both the physical well-being, but also psychosocial and emotional well-being of individuals affected with mito disease. It's also important to note that patients with mito are more vulnerable to metabolic decompensation during illnesses, fasting, or stress. So regular monitoring will help educate patients to anticipate and prevent these crises through education, early medical intervention, and emergency care plan institution. So now we come to the patient care standards. The various patient care standards have been developed internationally to aid the management of patients with mito. However, these guidelines may not always be applicable to the Australian healthcare setting, where there's a range of publicly available investigations that differ with our international counterparts, or treatments and long-term follow-ups may also not be congruous to our Australian setting. Hence, a whole group of clinicians, including Professor Caroline Su and myself and others, adapted an international guideline by the Mitochondrial Medicine Society, which was published in 2017. And this is the Australian version of it, entitled Patient Care Standards for Primary Mitochondrial Disease in Australia, an Australian adaptation of the Mitochondrial Medicine Society recommendation. The Mito Foundation has also published a simple version, which is easy to read, called the Australian Patient Care Standards for Mito Disease, referencing this adaptation. Now, because mitochondrial disease can affect many organs, as we have described, monitoring of the relevant symptoms is imperative. The unique way mitochondria affects us, so each patient or individual might have different symptomologies or manifestations. Hence, the organs that are involved will determine which specialists you need to see. This could be a metabolic geneticist, a neurologist, cardiologist, or a gastroenterologist, etc. Having one doctor who's familiar with the patient to coordinate the overall care is really helpful. And that might be a neurologist in the adult setting or a metabolic clinician in the pediatric care who generally coordinate these cares for our patients. So patients should have a personalized management plan, including for emergencies, when they have acute decompensation. And alongside medical management, it's also important to link into allied health therapies, for example, dietitians, physiotherapies, occupational therapies, speech therapies, etc. They all play a key role in providing an overall care and optimizing well-beings of our patients. So this patient care standard really emphasizes on a model that promotes autonomy and empowers patient to make informed decisions, to be aware of their disease trajectory, and to realize what needs to be monitored, when to escalate care, and when is it important to be involved in shared decision-making processes. So I'll talk about audiology. It's just alphabetically organized, the symptoms, not that hearing impairment is the most important, but hearing impairment is an important feature in multidisciplinary care of patients with Mito because auditory dysfunction is common and sometimes progressive manifestation of this disorder. So the cochlea, for example, is a highly energy-dependent organ in our human body. Untreated hearing loss impacts not only on communication, but education of children affected with hearing impairment, cognition, and social participation, which is very important. Children and even adults might feel isolated if they are not able to communicate effectively due to hearing impairment. So audiological assessments should be performed at initial evaluation or assessment, and then ideally at an annual to 2-yearly frequency. Whether this is practical is something that we need to look into. Hearing impairment may also need to be assessed more frequently in several instances. For example, if the patient or the individual is known to have hearing loss, or if they have a pathogenic variant in a gene that is more predisposed to hearing impairment, for example, the MTRRN1 gene with a specific mutation, or if the patient is potentially receiving ototoxic medication, so drugs that could potentially impact on the hearing apparatus. It's also important to avoid environmental triggers, for example, noise pollution or excessive noise exposure. Certain antibiotics, for example, aminoglycosides, may exacerbate hearing loss, particularly in patients with a variant in the MTRRN1 gene. So it might have to be restricted to absolute indication when it's necessary and if they have no other alternatives in antibiotics based on resistance testing. So there are various modalities to address hearing impairment using early amplification devices like hearing aids or cochlear implants are helpful and can improve outcomes. Speech therapy is necessary for assistance with individuals with speech and language development, and affected individuals should be referred for hearing support services and education liaison in the childhood age. Right. So next we move on to cardiac manifestations. So cardiac monitoring is essential in Mito patients as the heart is a high energy dependent organ and is often affected. The high proportion of patients, so as many as 50% of adult Mito patients and 40% of pediatric patients have a predilection or have cardiac involvement. And this may manifest as cardiomyopathy, which is a disease of the heart muscle that is unable or makes it harder to pump blood to the rest of the body. Or they may have arrhythmias, which is abnormal heart rhythm, or conduction abnormalities, where there's a problem in the heart's electrical system that controls its rate and rhythm. So these may progress silently until serious complications occur. Hence, they need to be monitored preemptively. So baseline cardiology assessment should be performed, and these include an ECG or electrocardiogram that detects conduction abnormalities. Additionally, an echo or echocardiogram should also be done to evaluate the thickness of the cardiac walls, the cardiac chamber, as well as systolic diastolic function. In general, adult patients should have annual ECGs to monitor cardiac status. And if there are conduction abnormalities, ablation therapy may be indicated for cardiac arrhythmias. This is a medical procedure where the abnormal heart rhythm is managed by targeting the scarred heart tissue that causes the irregular heart signals. A low threshold for pacemaker implementation is needed. And pacemakers are essentially small battery-powered devices that are placed under the skin over the chest that use electrical impulses to help regulate the heart rhythm. It can also sometimes be combined with an implantable defibrillator to help act on rhythm abnormalities. Additionally, exercise testing and/or stress echocardiography could also be performed. In the pediatric setting, exercise tests or stress echocardiography are undertaken in consultation with our pediatric cardiology support. Physical activity, including supervised graded exercise regimes, should be encouraged. And at the Sydney Children's Hospital Network, we're actually really fortunate because we have a sports medicine consultant who actually advises the Olympics team. So we are very happy to have her on board to help advise all our patients. So the next is gastroenterology manifestations. So the GI tract, so they have manifestations include dysmotility or bulbar muscle weakness. So bulbar muscles are muscles that are in the mouth and throat that control functions like speech, swallowing, and facial expression. Apart from that, liver dysfunction or liver failure may also manifest in patients with mito. It's important to monitor growth parameters like height, weight, BMI, and standard markers for nutritional status should be monitored regularly in a 6 to 12 monthly frequency. These include iron status, vitamin D, folate, active B12, and other parameters. It's important to assess caloric intake and micronutrient balance. This should be optimized with dietetic support preferably. It's also absolutely important to understand that caloric depletion can further perpetuate mitochondrial dysfunction and it becomes a vicious cycle. So we have a low threshold for referring our pediatric patients for either nasogastric tube placement or gastrostomy feeding if the oral intake is inadequate to maintain an appropriate trajectory in the weight gain. Suspected aspiration or bulbar dysfunction should be evaluated with relevant tests, including video fluoroscopy or fiber optic endoscopy, and speech pathologists are involved and they can advise on various feeding strategies. Gastric emptying and colonic transition studies can also be performed, and there are several medications which may have already been touched upon. Might not go into the details, but just I think Isabella, someone has already, yeah. Next, so we have neurology. So this is a really important category of disorders that affect mito patients. So the nervous system is probably the most frequently affected organ systems in mito. Patients might have a wide category of spectrum of manifestations, including headache, migraine, stroke-like episodes, movement disorders, muscle weakness, and encephalopathy. So encephalopathy is a form of brain malfunction. It may range from mild confusion to memory loss to severe personality changes, lethargy, and coma. Some of these features can be life-threatening. In pediatric patients, it's important to have neurodevelopmental assessment when the child's around 3 to 4 years of age and formal neuropsychological testing before they start school so that we can have early intervention programs instituted into their overall care. Regular neurological assessments can detect early changes, guide management, and prevent complications. Hence, it's important to surveil of these associated features. Patients with epilepsy should be assessed by EEG or electroencephalogram, which is a non-invasive test that records the electrical activity of the brain. It's also important during regular clinic reviews to ask what anticonvulsant therapy patients are on. Valproic acid, for example, should be avoided in a specific mitochondrial nuclear gene defect known as POLG-related disease. And if patients have liver dysfunction, we have to be cautious about using valproic acid because it could perpetuate liver disease and exacerbate liver failure. And we have seen that in some patients. Headaches and migraines should be appropriately treated. And it's also important to note that sudden onset focal neurological features or worsening severity of migraines may herald the onset of stroke-like episodes of seizures. Myopathy, important to evaluate for muscle function. We have got biomarkers in blood, particularly creatine kinase and perhaps some others as well. Exercise therapies, important to have a sports medicine consultant or exercise physiotherapies on board to help advise on a graded exercise program, for example, submaximal aerobic exercise, and each patient should have an individualized program. Stroke-like episodes, I think it's already been discussed, the use of intravenous L-arginine, which is a vasodilator, which helps reduce the severity and frequency of stroke-like episodes in all our pediatric patients with MELAS or mitochondrial encephalopathy, lactic acidosis syndrome have individualized emergency management plan with L-arginine as a therapeutic option if they present within the first 3 hours with a stroke-like episode. So fatigue, I think Isabel has touched on it. This is a common and often disabling symptom in Mito patients and probably underestimated as well, the impact that it can have on patients. It arises from a combination of physiological, cellular, and psychosocial factors. It may present with persistent or fluctuating muscle weakness, exercise intolerance, sleep disturbances, or non-restorative sleep patterns, cognitive getting tired, cognitive slowing, and may also be exacerbated during periods of fasting and intercurrent infections. So it's really important to evaluate for symptoms or potential causes for worsening fatigue, and this could be attributable to treatable etiologies, for example, cardiac features or respiratory insufficiency, or if they are associated nutritional deficiencies like nutritional anemia or endocrine dysfunction or worsening myopathy. So monitoring can be performed using patient reported fatigue scales or by exercise testing, where they look at the oxygen consumption or lactate response, biochemical monitoring, and measuring endocrine function like thyroid and adrenal function. So while fatigue cannot be entirely eliminated, it can be managed through a multidisciplinary approach, and this includes exercise therapy, as I've briefly mentioned, so graded regular physical activity. It's important to not overexert the individual because that can trigger lactic acidosis, and also have energy conservation and pacing strategies. So structured rest periods throughout the day and pacing the activities to avoid energy crashes. The exercise physiotherapists might be able to advise on moderate intensity aerobic exercise, which pushes the patient up to 70% of the maximum heart rate to improve baseline levels of fitness. And it's recommended for those who can exercise. The exceptions are those with cardiac arrhythmias or cardiopulmonary involvement, where you need the cardiologist involved to advise if that's a possible mechanism, exercise therapy. So patients should have tailored exercise programs where possible, involving their exercise therapist, physiotherapist, or sports medicine physician. So while no cure exists, I think Isabel has already talked about targeted nutrition supplementation, which is really important to optimize mitochondrial function, reduce oxidative stress, and improve energy metabolism. And this can be established by having a well-balanced diet, regular meals, avoiding fasting. Various supplements have been used to reduce oxidative stress and mitigate free radical damage. There's no standard mito cocktail, but some of the supplements we use include vitamin C, thiamine, riboflavin, coenzyme Q. The benefits of ketogenic diet, which is a high-fat diet, are not fully established, but have been used in patients with Mito disease with epilepsy, particularly due to complex 1 deficiency. However, this is not really well established. Now, I'd like to focus on this, mental health and well-being. I think, again, this is an underestimated aspect of Mito disease because there are so many other overwhelming features to address that people actually forget about mental health and well-being. These are key aspects for the overall care of people living with Mito, and it's as important as physical health as well. So, patients frequently experience a high prevalence of mental health issues, and this could be linked to the disease's impact on the brain and energy-dependent cellular functions. The symptomology may include depression due to chronic fatigue, progressive disability and pain, and very often because they feel that they're not heard or listened to by their clinicians. You know, sometimes clinicians brush it off as psychosomatic disorder rather than understanding it's part of the overall plethora of manifestations in Mito disease. Anxiety, not infrequently reported in patients, and even in children. They have anxiety. You'd be surprised if you actually delve into children have anxiety when they have chronic disorders, and it's linked to their fluctuating symptoms, fear of deterioration, and fear of not being accepted in their peer group. Cognitive issues, problems with memory, attention, processing speed, or adjustment difficulties due to the ability to cope with a diagnosis of a rare chronic disease. They challenge their self-identity, and it impacts on their emotional stability. Carer stress and burnout. So in the pediatric setting, we don't only deal with the patient, the child, we actually look at the whole family as well. It's really important because the parents look after the child. They should also be well, in a good mental space, because they can end up with carer stress and burnout. So they experience a lot of psychological strain as well. So it's really important that you reach out to your doctor. Your GPs might be able to help in coming up with a mental health care plan. Early recognition and intervention improves overall well-being, not just for the patient, but as for the family unit as well, and that is important. So ongoing psychosocial support helps the families build resilience, maintain quality of life, despite their chronic challenges. So counseling and peer support group is really important. Staying connected with your community, and I think it's really important, engaging with the Mito Foundation, for example. They have got a really excellent, comprehensive program that reaches out to people and fosters connection and understanding. Peer mentoring can reduce the isolation faced by lots of patients with chronic diseases. So just to summarize, just very brief of the ongoing monitoring. So annual heart checks. Nutritional bloods includes, kidney, liver function, and micronutrient assessment. Eye and hearing checks every 1 to 2 years, mental health and fatigue assessments, and also just reviewing the medications that patients are on, because you might find that a patient with epilepsy is on valproate and they need to stop that. So in conclusion, even though mitochondrial disorders are chronic and largely incurable, today, the approach has largely shifted from basically one of despair and helplessness to a more encouraging focus, not just on diagnosis, but also on early identification of signs and symptoms through regular surveillance and symptomatic care through the optimization of energy production, nutritional support, avoidance of toxins, meeting lifestyle needs, education, prophylaxis through health, living and monitoring for complications. So supportive treatments remain the mainstay. However, there's a whole plethora of other issues that need to be addressed and that can also be identified through monitoring and surveillance. So it's a proactive care, not reactive. Consistent reviews helped prevent complications, and collaboration between the patients, families, and specialists is really important. So it's all about empowering, providing autonomy to patients and their families, and you are the center of your care. So you actually advocate for your child or for yourself and your family for coordinated care across the healthcare service. Just like to highlight several excellent information resources available on the Mito Foundation webpage. I actually refer all my patients to the foundation webpage, and I actually print them out sometimes because they're really helpful. Thank you. Thank you.